CACP affiliate organization. But I will introduce our last two speakers. We have Dr. Seferina Kim. She is a graduate of the University of Maryland School of Pharmacy and has worked in a variety of specialties, including adult internal medicine, oncology, transitional care, and general ambulatory care. She is currently clinical staff for the School of Pharmacy with the primary site at the Outpatient Medication Therapy Management Clinic at the Medical Center, focusing primarily on anticoagulation and nephrology. Dr. Kim also serves as the coordinator of the PGY2 AmCare Pharmacy Residency Program here at Maryland. And she's also the chair for the Intimate Partner Violence Collaborative at UMB and is chair of the Anticoagulation Stewardship Committee at University of Maryland Medical Center. She is currently completing her interprofessional program for academic community engagement fellowship at the Community Engagement Center with UMB's Multidisciplinary Health Alliance. And then we also have Dr. Kaitlin Landolf. She is a critical care advanced practice pharmacist at the School of Pharmacy with her practice site at the University of Maryland Medical Center in the medical ICU and neurocritical care unit. In her role, she precepts students, PGY1 and PGY2 residents, and pharmacy fellows, where she works to incorporate trauma-informed principles in her precepting and teaching style. And they are going to talk to us about trauma-informed precepting.
All right, thank you for the introduction. I'll go ahead and get started with the first part of our presentation for today. But before we get started, I wanted to just make sure we have a discussion beforehand that some of the information in this presentation may be distressing. In particular, there's a more particularly distressing slide that we'll spend a few minutes going over that we really included just to show you guys how prevalent trauma is in people in the US and in general. Affecting multiple different demographics, and the numbers are pretty high. So just want to let you know that. And if at any point in time you feel you need to take a wellness break, please feel free to step outside of the room if you need to take a break from the topic. But overall, once we get through that one slide, we'll be focusing more so on what are the principles of trauma-informed precepting and learning and how you guys can incorporate that into your precepting rotations. So the objectives of this presentation are to recognize those behavioral and emotional signs of trauma in your learners, understand the principles of trauma-informed care, and apply this to your teaching style and establish a safe learning environment, while also being able to refer learners to appropriate support services when needed. It's really important before we get into this talk to kind of understand and be on the same page about what trauma is. So the Substance Abuse and Mental Health Services Administration, SAMHSA, has a definition of trauma that's kind of in line with the DSM criteria for trauma for people that have faced trauma or stressful events. But trauma is an event, a series of events, or a set of circumstances that are experienced by an individual as a physically or emotionally harmful or life-threatening event and has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And we'll talk about this too, but there are 3 E's of trauma that you might notice in this definition: events, experience, and the effects. And you'll see those later on. So this is a slide that has some pretty astounding statistics, right? So you can see from this slide, this is from a national survey of domestic partner violence and intimate partner violence. And in this annualized survey, they found that up to 50% of females reported having some sort of sexual violence in their lives. And this is also a pretty high number for males as well. So 30% in that survey had reported undergoing some sort of sexual violence as well. And then children are often affected by trauma and are victims of child abuse and neglect as well, with pretty high statistics in the literature. You can see too that victimization rate for females might be slightly higher than that for males. And what they found too in some of those populations where people are marginalized, that American Indian or Alaska Native children have pretty high rates of victimization at 15 per 1,000 children. And then the African American children have the second highest rate per children of the same race or ethnicity. And then also here, pretty high statistics of youth experiencing physical assault in the past year, 37%. So this was a survey of traumatic exposure in children that found these statistics. And again, kind of going back to that initial domestic partner study survey, 1 in 4 women had reported completed or attempted rape during her lifetime, and 1 in 9 men have reported being made to penetrate somebody during their lifetime. And then what about kind of closer to our age range? There's not a lot of evidence in terms of people that are postgraduate training, the trauma that they face, but we can get kind of close to that looking at trauma in college students. And so up to 66% of incoming college students, some studies have reported up to 84% of college students having reported trauma either before they get to college or while they're in college. So those are pretty high rates. And so a lot of people may have experienced trauma or are still experiencing trauma in their lives. And so this is important that you might have learners on rotation with you who have experienced trauma or undergoing trauma. And perhaps the way that you're precepting could cause problems or, re-traumatize those people, those students and learners, or even some of the events they might see on rotation or the patient situations might be some sort of vicarious trauma or re-traumatization that your learners may experience. So it's pretty prevalent, and it could be impacting a lot of people in the age range that we might be precepting. We find that marginalized populations oftentimes have higher rates of trauma, populations like people that are military veterans, even non-traditional students that might be older. There are pretty high rates of trauma in those individuals as well. And so this impacts everybody, and you never know when you might have somebody that's undergone trauma. So SAMHSA, in their definition of trauma, I already alluded to this. There are the 3 E's of trauma. There's an event, an experience, and effects. So there's an event, some sort of incident, some sort of sexual violence or some sort of assault, a natural disaster, a pandemic, different events. Maybe somebody is a refugee. So there are many different events that could be happening, causing trauma or exposing people to an event that could possibly be traumatic. So it's important that we recognize that, one, there's an event in what's considered trauma, and then the experience. So this is that subjective, emotional, psychological response to said event. Of note, not everybody may have trauma after they experience an event that could be traumatic, right? So one refugee having to flee their country could be having a very different experience compared to another, where some might be relieved to be leaving, where others are going to be facing like horror or other traumatic events could be causing things to that cause people to have horror and like poor responses, helplessness to their situation. So everybody is going to experience an event differently. And then effects, right? So for something to be considered traumatic, right, there is either a short-term or a long-term effect. But we know that people that experience trauma, and for an event to be considered traumatic, that there is a lasting impact on their life in some way, shape, or form. It could be things like PTSD, difficulty with relationships, impacting their ability for cognition and things like that. So why is this relevant to precepting? Well, trauma impacts the brain, right? So we are helping people on rotations or while we're precepting them learn new things. And so you need to have, in terms of creating a memory and learning things, usually you have a positive experience that will help you form a good memory. However, if you have bad experiences or something that brings up bad experiences, it might hinder the person's ability to form a memory and retain information and kind of use that going forward. It's important to first kind of look at the different parts of the brain that are involved with this, right? So the amygdala is going to be that part of the brain that will sense a stimulus, and it's either going to interpret that as stressful or not. And then it's responsible for how your brain's going to function thereafter, right? So say you have an event like a natural disaster. Is this going to cause stress? Yes or no? And that's where the amygdala is kind of stepping in. And then you have the hippocampus, which is really going to be important for differentiating between past and present, forming memories and committing those memories to your brain. And the prefrontal cortex then is going to be that area that's responsible for mood regulation, emotional regulation, rational thought, cognitive functioning. And so when you have trauma, you can have possible changes in the structure and functioning of the brain. Your amygdala is going to be overactive. So stimuli that maybe weren't necessarily life or death before, say somebody came back from war, there's a loud noise, the stimuli that is like a book falling on the floor might make them kind of their body feel like it's life or death situation and bring up those memories and PTSD. So you have this amygdala that's overactive. It's causing more response, more stress to an event that shouldn't be stressful, but is for that person. And then with your hippocampus, this area is going to shrink. It's going to make it more difficult for the person to form memories and differentiate between what's past, present, and commit memories and learn things. And then your prefrontal cortex is going to shrink. So people may have alterations in their ability to respond. They might be more emotional, unable to kind of like regulate their thoughts. And we'll kind of see on future slides kind of what that looks like. So going back to SAMHSA really quick, they also have these 4 key assumptions, the 4 R's of trauma, right? So you have this part where you realize that trauma is ongoing. So this is important for like institutions and programs to understand, right? And having these components will help those involved in the program be able to perform trauma-informed learning and teaching. So there's this realization that trauma is happening, it's high rates. You have to recognize that people are going to have faced trauma and are currently facing trauma in their lives. So an organization that's really practicing trauma-informed care will take these things into in mind when they're doing different endeavors or just expecting people to come to work and things like that. And then the other things too are to respond to trauma. How are you going to prevent trauma from happening, make your workspace a nice, safe environment for people, and then also resist re-traumatization and help people avoid situations that might make them have feelings of re-traumatization or things that bring up those memories, feelings, and responses again to trauma. So signs and symptoms of trauma, I kind of mentioned on the brain slide, right? Is that people might have hypervigilance, right? So they're going to be hypervigilant to a stimulus. They might do things like avoid different things in their life, right? So avoid activities of daily living or avoid work that needs to be done at work or things that should be done on rotation. They might just have this avoidance when they are having signs, when they're undergoing trauma or things bring up traumatic feelings for them. They may have reckless or self-destructive behaviors, might be socially withdrawn. And I mentioned like kind of difficulty forming relationships with others. It might be aggressive when normally a situation wouldn't call for aggression. As I mentioned, cognitive impairment, difficulty forming memories, being able to retain information, being able to recall information. They could have flashbacks, nightmares, so things impairing their sleep, anxiety constantly, depression constantly, guilt or shame, and impaired coping mechanisms. So something that wouldn't normally cause such a large reaction might cause that, or they can't cope with everything going on and therefore aren't able to kind of live their life, do activities of daily functioning and things like that. So kind of what would this look like on rotation? We just put a few examples here of what that could look like on rotation, right? So you might have a learner who has difficulty focusing, retaining, recalling information. They might have anxiety about deadlines, anxiety about speaking up and talking to providers or other team members or talking to patients in different situations. They might feel helpless, or when they're stressed might just dissociate and like not really be engaged at all. And so that can be tricky to try to teach somebody who's dissociated or doesn't want to be there or feels helpless in helping themselves. And then for instance, like sleep disturbances. So people might be late to rotation if they're having nightmares or they're not able to sleep because of the trauma that they are facing or have faced. And so that kind of leads us into trauma-informed care and how do we put these principles that we'll discuss in our rotating precepting.
Kind of a downer subject, right? So when we came up with these slides, we really designed them for preceptors, right? And I know just seeing all these faces, I know many of you guys are incoming residents. So while I want you to incorporate some of these as you start to take learners on for yourself, I want you to also apply some of the principles that we talk about to yourself if you feel as though you're kind of in an uncomfortable situation. So just kind of these principles that we talk about, these assumptions that we talk about, yeah, we might be presenting them in the context of a preceptor to a learner, but they're also very important in terms of self-care. So SAMHSA has a really great PDF that talks about what trauma-informed care is. It can encompass a whole bunch of different organizations, operations. It can go from a macro scale to micro scale. Kaitlin had mentioned the 4 R's about, recognizing the trauma and responding to it, et cetera. In addition to those assumptions, it also has 6 different principles that it uses to guide your operations, or to guide your policies or your care. I'm going to spend a little bit more time on each one of these principles, so in order for you to apply them in your rotational and teaching experiences. So the first principle is about safety. So we're really not just talking about physical safety, we're talking about both physical and emotional safety. In terms of preceptor to learner, we really want to create a safe and supportive environment where your learners are able to communicate with you about what they're feeling like, but you may also want to ensure that you're say you work in a high-risk population, I'm thinking more like maybe a psych rotation, you want to make sure that your learners know that there are safety plans in place for their physical safety as well. So the first is to create a safe and supportive environment. The second would be trustworthiness. And so we're talking about having very clear and transparent goals with your learner. This could be maybe in the beginning, before your rotation starts, making your expectations and your learning objectives to your rotation very clear and easy to read, easy to follow. Another one would be peer support. So we're talking about learners that may pair up with other learners, and this could be anything from supportive group conversations, someone to commiserate with about the rotation. Of course, they never need to do that though, right? Because rotations are always the best. But just having someone that they can talk to that's their equal in a safe space. The next is, you can see how they kind of all interplay with each other, right? So we're talking about collaboration, which then could come from your safe environment that you've created. We're talking about fostering collaboration, respectful relationships with learners, having learners make choices. So that would be empowerment and choice, getting their perspective in your teaching rotation, right? So as an example, I teach a variety of learners. I teach PGY4s, or excuse me, P4s. I teach P3s. I do PGY1 pharmacy, PGY2 pharmacy, PGY3 IM. They all have totally different expectations and they all have totally different professional goals. So what I like to do at the beginning of any rotation that I have is I tell them, bare minimum, if you're here with me for anticoagulation, you're going to learn how to do warfarin. It's one drug, big deal. You got it. But in addition to that, what do you want to see? What do you want to do? Do you want to do more direct patient care? Are you uncomfortable with patient care? Do you want to learn more about the operational sides of things? So you kind of let your learner have a say in how the rotation goes, and it helps to foster that collaboration. It helps to create a safe environment. The last thing is acknowledging cultural, historical, and gender issues. So these are a little bit more like looking at the background, right? So to acknowledge that there are different aspects of identity that your learner may bring into this, and how that may potentially inform some of their experiences and their interpretations of their trauma. So a couple of different, I thought we changed the order of the slides, but that's okay. So a couple of different ways that we can apply some of these principles into the rotation. Before your rotation begins, and this is true of residents too, when you get your syllabus and your learning objectives, make sure it makes a lot of sense. Make sure that it's very clear, that you understand the expectations. If you know that it's a setting that may be triggering to you, have a conversation with your preceptor. Preceptors, if you know you work in a setting that could potentially be triggering, go ahead and preemptively throw it out there. So I don't know, I think I see some familiar faces from my physical exam lecture on Monday, but because there's a lot of touching there, right? And there's a lot of examination. I started out the class by asking people, if you're uncomfortable with this, let's talk about it, right? So you may want to do something like that. During the rotation, you want to continue to create a supportive and learning environment, following Dr. Bethula's feedback lecture and, not using the U's and just kind of creating a collaborative, safe environment. In addition to that, you want a role model. So let your learners see you interact with your patients and seeing the sensitivity that you bring to this. You may want to also have debriefing and reflection sessions. So during your Feedback Fridays, we've now learned a whole bunch of different uses for Feedback Fridays, right? Like, so we're using it to measure a learner's growth through the rotation, but we're also using it as a chance to check in with our learner. And you guys should be able to do that with your preceptors as well, you know, saying, I'm really uncomfortable with X, Y, Z, and I really need help processing whatever. So I think that that's something that we should be doing just kind of generally across the board, whether or not we know that our learners have experienced trauma. And the last thing is resisting re-traumatization. And that's really hard to do, right? Because we don't know everyone's experiences, but as long as we are aware of these situations, I think we will make much better choices, you know, sort of better language, better sensitivity. So we want to, as preceptors, address students' discomfort if they express any. We want to, you know, validate their feelings. We want to you know, kind of normalize that trauma is a thing. I mean, you saw that slide. Like, the chances are you have experienced trauma, or the person next to you, or two seats down has experienced trauma, right? So we want to make this kind of a normalized experience and validate it. We want to provide ongoing support and supervision, right? Like, as preceptors, and residents will learn this too when you have your own students. As preceptors, we have a duty to protect our students. And so we want to provide ongoing support and supervision. And at the end, we'll have resources for those that feel like you're kind of coming up to a problem that's sort of outside your scope. There are at least being able to send learners to the right resources that could better assist. And we want to incorporate a lot of these different principles into our practices, into our regular curriculums and evaluations. There are, of course, challenges to this, right? You know, a lot of people are not aware, right? But you guys are doing the first thing by staying after a whole day of lectures, like staying with us and continuing to learn. So that's the first thing, is kind of continuing to encourage training or reading. Sometimes it is a challenge to actually make the time to sit with your learner and talk about these things. But that's why I said, you know, like, take advantage of the Feedback Fridays and just do a mental check-in. A lot of us that decided to become pharmacists, we're all doing this for the good of our patients, right? Like, we really love to take care of our patients. We, in doing so, many of us, I think, are susceptible to what we call compassion fatigue or vicarious trauma. You know, you develop a relationship with your residents or your learners for 5 weeks, and near the end, you just kind of just feel this tug for them. And we need to, as teachers, really learn to set our own personal boundaries, and essentially do all the great things that Shani had said about self-care and really learning to take care of yourself and not letting that kind of plague you, and knowing how to address your own needs. So we have 6 minutes until the MSHP emerging practitioner thing begins. If you guys that are residents that were planning on going to that, if you guys want to start this breakout group, I think we could probably do it. Yeah. Okay. So what I would like to do, and I know it's like the dreaded group project that someone's going to have to present. Yes. But I want to have a conversation. If you guys want to kind of, maybe based on location, break into groups of anywhere between 4 to 10-ish, figure out a way to apply one of these 6 principles into your rotation. And I know a lot of you guys are residents, so maybe you don't necessarily know how to do it yet as preceptor to learner, but I'm sure you remember 4th year. Try to come up with a way that you think it would have been better to approach a potential issue. And then in 10-ish minutes, we'll all just kind of have a group conversation about it. And if you guys want to go, that's totally fine. We went over the bulk of the information. And at some point, I think we'll probably send out the slides, just so you guys know that there are resources. The only update that I would have to this is 211 is turning into 988. But if you guys want to take a picture of it, but we will send out the slides so that you guys have these resources available to you. Yeah, go ahead and talk amongst yourselves. How do you? I wasn't paying attention.
We're forming groups. We're identifying one change you can make into your rotation by any of those 6 things down there.
Find at least one of the principles of common and care. Transparency, that like, yes, transparency that this is there, you might see something difficult. And
I think it would be good. I'm sorry, I didn't mean to cut you off.
no, I don't.
I think like you're talking about like the transparency of like knowing that you're in a risky rotation, right? Like regardless of where it's at.
Yeah.
I think I would like to see something like in the safety part of that saying like, I know that this is possible to happen. If this happens, this is what you do. Like I want like a safety plan. Do you know what I mean? Like, should you come in contact with a patient that, you know, triggers you, does whatever, you are allowed to go to this room to decompress and I'll come find you later, right? Like this
Yeah.
can be where you go, or this is what you do.
Yeah.
This is how you tell me, or this is like our safe word when you need to just leave.
Yep. I think that's good.
I would like a safety action plan.
Like it's
Done. Let me get my booze.
giving you choice. You know who you're gonna go deal with, that there is someone. Giving you the choice to sit out. You don't have to do this.
It's just in there.
Okay.
So I'm confused. Are they leaving now to go do that happy hour thing? Just like a fun.
Yeah, I don't think there's so much she said that it's special for our. I don't think that's
I don't think that's true either. Maybe some of them have something else to do.
Oh my god.
Amanda, I thought the happy hour thing started at 5. Yeah, that's what it said on here. Okay. Really? Yeah. Okay. Where they go?
What's happening?
Across the street, the atrium.
Oh, is it like a happy
Yeah,
hour?
it's like the Maryland Health System Pharmacy group, and SHP or whatever, they put on like a little welcoming thing.
Oh.
Yeah. But, yeah, our calendar says 5, so.
Yeah.
Yeah, especially if it's not started. So you walk over there and nothing's happening. And it's like,
Hello? All right, we're getting a mass exodus. So we'll just like talk briefly. Seeking volunteers. Shall be, oh, yes, Sam, go for it.
Yeah, I just talked about it, so I'll repeat it. So
Yeah.
on a PICU rotation, so I was a part of a kind of like a code, but it was a very long, like 3 to 4 hour sequence of a child decompensating, and it was a very stressful situation. Afterwards, my preceptor, we debriefed for about 30 minutes after the situation. So both the clinical end, but that came after. First was some time to talk about what I had experienced and how I felt about it. And the next day, early in the morning, that preceptor actually told me his significant other was sick and just stay home and work on some projects. After the rotation ended, I did some reflecting, and I thought, I don't think that was actually the case. That preceptor was probably looking out for me and gave me a day off to just decompress after what had happened. And following some of that, it just kind of left an impact on me to realize that if I ever have a student, I want to be able to look out for them in the same way. Just pointed out that knowing me, if that preceptor directly asked me, do you want to take a day off? I probably would have declined. So I think knowing your student or your learner and their habits and nuances is probably a good way to precept. So that was an impactful moment for me that I will try to emulate going forward.
Thank you for sharing. That is a great example. A lot of our P4s have this need to do whatever the preceptor says, right? This sort of people pleasing. I mean, you guys know, you guys are here, so you all have amazing CVs, so I get it. But there's this like desire to just be this people pleaser and always say yes. And so really having a preceptor look out for you and trying to continue to foster a very safe relationship, I think that's a great thing. Yeah, he probably said was giving you a day off. Any other examples?
So I work in, yeah.
Oh, can you talk into the mic? No, try again.
Okay, so I work in pediatrics, and especially recognizing that many learners probably don't have previous experience with pediatrics, maybe going over like things to expect in the beginning. And frequently I have a lot of patients who may come in with difficult social backgrounds, whether it's child abuse, child neglect, patients who are sitting on my team for a while because they're just awaiting some kind of social services placement. So kind of opening that door early and letting learners know that these are things that you may see if you ever feel like uncomfortable, or if you want to talk about anything, debrief. So kind of different from the patients like actively dying, but still something that they may be very sensitive to. So just trying to open the door early.
Yeah, I love that because you're sort of being very transparent about how your rotation goes. And again, you're sort of fostering a very emotionally safe environment, which is fantastic, right? And it also shows kindness. It shows us a certain sense of empathy for both the patient as well as your learner. So thank you. Anyone else?
So I work in pain and palliative care, and so I think something that I am going to incorporate going forward is at least like checking in with the learner at the start of the rotation to kind of understand like, okay, what are their experiences with the death and dying process? Because I know not some of like the pharmacy learners necessarily, but the medical learners that we've had recently, there's been a couple of them who had trouble just because of a recent death of a loved one and things like that. And so I think that's something that's important to consider, especially because it is a little bit more up close and personal view sometimes, especially when you're managing symptoms of a dying patient, like in the room, you know, holding their hand, talking to their family, whatever the case may be. And then the cultural and historical aspect kind of just made me remind of Dr. McPherson's presentation about for pain and palliative specifically, like how do these different belief systems influence decision-making when it comes to, you know, medical decision-making. So being able to talk about that and explore that a little bit more with students and residents.
Yeah, thank you for sharing. I think medical residents have that same, I can't say problem, but this sort of same need to impress whoever it is that their attending physician or their preceptors. And I think by acknowledging that preemptively, I think that could potentially go very far in creating a safe environment. Especially, you know, just as a personal story, I personally find what you do incredibly difficult. And anything peds, like I can't do dying and I can't do peds. Like I know my limitations, like I'll just start crying. So, and just being very aware that it is a very sensitive subject for a lot of people. Thank you. Anybody else? Oh, in the chat. Let's check the chat. Yep. Okay. All right. Well, thank you guys for sharing and for actually also discussing. You know, I know sometimes maybe you don't want to talk in front of a group after 8 hours of being in classes all day and kind of want to get out of here. So I really appreciate you guys getting together and discussing different strategies and ways of really validating and making a very rich environment for your learners as well as your preceptors. So in conclusion, we just want to say that this trauma-informed care is a transformative approach that really prioritizes well-being, is and holistic development of your learner. And you can, again, take a look at the SAMHSA website, but it really integrates the 4 R's as assumptions and the principles of safety, trustworthy, transparency, peer support, collaboration, empowerment, as well as recognition of cultural and historical gender identity issues. But it really, I mean, the whole point of this for us is that it really helps to create an environment that's conducive to learning. And if someone is in an environment where they can learn, they are definitely going to grow. And, you know, as Dr. Bethula had mentioned earlier, we're talking about professional growth, but a lot of times you will see personal growth during the rotations here. We will go ahead and send the slide deck out so that you guys are aware of the resources here locally. I'm not sure how many of you guys are from Maryland, but as I mentioned earlier, 211 is currently being phased out. You can still call 211. It is the Health and Human Resources. So like as an example, this would be the resource I would go to if someone needs assistance with like counseling, you know, not necessarily 911, but they need help. Well, now 988 is taking over all of it. So I called them today. And so if you need someone that needs assistance with outpatient counseling, 988 is going to take over all of those services, and it is 24/7. For those of you that maybe you have some issues that you need to talk about urgently, I wanted to include employee services here. So we have UMMC, EAP, as well as UMB. So depending on where you're located, and all the hospitals have employee assistance, right? So in addition to that, University of Maryland carries a RISE program, which is resilience in stressful events. It is a Tiger Connect role. So if you guys just need someone to talk to, please just know that there are a lot of options for you. All right. If you need to contact us, here are our email addresses, and have fun at the dinner.